tonight as we are going to talk about kind of screening both still during and post, the first COVID sort of wave, and how are we handling getting patients back in for screening. We are really excited to have Dr. Nye join us. As you see, she's already jumped on. And Dr. Greiner is going to be a little bit late, but he will join, he promises, to talk about colorectal cancer screening. So I think we have a great discussion. And then we have two special guests tonight. We have Chevelle and Tara, who are from the Early Detection Works. And Tara was having some connectivity issues with her camera. So you will hear Tara, but you won't get to see her. And we'll hear some kind of real life experiences of utilizing the Early Detection Works program in the state of Kansas, and how that can really impact a lot of our patients. And I think is a great opportunity, especially as some of our patients have had transitioning insurance or job furloughs and loss. This really is a time where we need to be thinking about how we can make sure our patients have the care and services that they need. So we will start, as we always do, with a little housekeeping. So let's jump in and put some slides up to help us with our housekeeping. And can you guys all see the slides okay? Great. So there is, and Dr. Sinclair will hopefully join us as well. We will see if he has time. He was in clinic today, so we'll hope he can join us. We'll go through our agenda for tonight. We'll do quick housekeeping. We'll do a little didactic, and the cases are sort of blended in tonight. And we also want your discussion as well as part of our building community of practice. So as always, we'll have a few poll questions. We'll do a quick kind of test run. And then we'll also want you to engage in some of your experiences, hopefully, with getting patients back into screening and using the Early Detection Works program. And then a little wrap up. As always, you get continuing education credit regardless of your discipline. And we also have our disclosures, which it seems like I'm the only one that ever has a disclosure. So there you go. This is your continuing education credit identification code, which is 19 Rome. You can email it, you can call it in, you can text it in. So there you go. And please make sure you do that by next week, if possible. Although Mary Beth Warren will gladly give you credit. She likes to give you credit in that window. So please be mindful of your credit window using 19 Rome. All right, we want to thank the Centers for Disease Control, the KU Cancer Center, and the Masonic Cancer Alliance for their ongoing support, providing us the opportunity to have this Project ECHO and bring all of us together in our shared community across the region. And we have visitors from across the country as well. So in light of that, let's do a little bit of check-in and see who's here tonight. And we have some new folks as well as some return folks. So why don't we start with some of our new guests tonight? And we're going to start with James Bond. Daniel Craig, you're up first. Tell us who you are and tell us kind of who you're affiliated with, and we'll get to know you a little bit more.
Great. So my name's Daniel Craig, and I work at Tammy Walker Cancer Center. Do their outreach. Background is a lot with tobacco prevention cessation programs in the community, and then I also do a lot of the cancer screening events, such as our annual colorectal screening.
Great. Well, thanks for joining us tonight. We appreciate it. All right, and Evelyn. Evelyn, do you want to say hi? And you are on mute.
Yes. My name is Evelyn Cooper, and I work with Faith Works primarily. So I'm working mainly with Christian experiences and acceptance of diagnoses and some other disparities within the Black community.
Great. Well, thank you, Evelyn, for joining us tonight. And is it Lainey or Leanne? I don't want to butcher your name, but if you would pronounce that for us and introduce yourself. Last name Howard. There you go.
Hi, it's Leanne, and I'm with Advent Health Shawnee Mission. I'm the oncology nurse navigator for head and neck and lung cancer patients, and I cover breast cancer patients as well at times.
Great.
So thanks for having.
Great.
Yes.
Thank you for joining us.
Thanks for having the series. I appreciate it.
You bet. You bet. And Dr. Barr is on and usually just says hi in the chat box. But if you want to jump in and say hi, we'd love to hear from you. Peggy Johnson, you want to say hi?
Here I am in Vermont. That's my virtual background. Isn't that great? I'm Peggy Johnson. I'm a longtime breast cancer advocate, worked with EDW in the very, very early years. And I saw this topic and thought, I need to hear this stuff. So I'm a common volunteer and I'm executive director of Wichita Medical Research in Wichita. And
Great.
Glad to be here. Thank you, Jennifer.
Thanks, Peggy, for joining tonight. All right. How about Rebecca?
Hi, guys. I am a quality improvement advisor with the Kansas Healthcare Collaborative that's based out of Topeka, is our home base. I am working with multiple clinics throughout the state of Kansas right now, trying to make a dent in the cancer screening rates for breast, cervical, and colorectal.
Great. Well, we appreciate that, Rebecca. And we also have some other collaborations with you coming up. So we look forward to getting to know you better as well. So Angela.
Sounds like a winner.
Yep. Angela, do you want to say hi?
I'm sorry, I had to take it off mute. I'm Angela Williams. I'm the community health educator with the Masonic Cancer Alliance Outreach Network of the University of Kansas Cancer Center. And I conduct health-focused outreach, primarily focusing on colorectal cancer. Secondary focus is breast cancer, cervical, prostate, and lung screenings in communities of color, primarily African-American populations.
Great. And Angela, I've heard your name before, so it's great to virtually meet you. And especially during our discussion on colorectal cancer screening, we look forward to you chiming in and joining the conversation.
Okay, thank you.
You bet. All right. Who else has Lori? There's two Loris. Lori 1 or Lori 2, or you may be the same Lori. All right. How about Kendra? Do you want to say hi, Kendra?
Sure. Hi, everyone. My name is Kendra, and I am the project manager for Dr. Klem's R01, the Cancer Survive, and then doing a lot of clinical research with Dr. Nye as well. So hi, everyone.
So, and we did not coerce you to join tonight, so we're glad to see you.
Yeah.
So, all right. And Lori, oh, it's Lori Winfrey from LMH. Hi, Lori. We are glad to see you back. We haven't seen you for a while, so hope you're doing well. And how about Jan? Do you want to say hi from the ECHO Hub?
Hello, everyone. I'm Jan Lyon. I'm with the KUMC Project ECHO. Glad to be here.
Great. All right. We will not let Carla get off of mute, but Carla is a jack of all trades and is part of our ECHO team. And Trish, do you want to say hi? Great. All right. Carol Bush.
I'm excited to be here, and like Peggy, I actually have been involved with early detection works back when it was part of Free to Know, and I managed a multi-county public health cooperative in 1999. So
that's kind of when I first came across you guys. We were part of the Free to Know, and I got my very first little grant for like $7,000 from Free to Know back in like 1997. So hopefully KU will re-engage, and we've had some good discussions about bringing EDW back to the home front. So we will update you all hopefully soon. All right, Dr. Wright.
There we go. Hi, my name is Shauna Wright. I'm a licensed psychologist, and I am the Associate Director of KU Center for Telemedicine. So glad to see you all today.
And then you all know Tracy, who is our Oz. Tracy says hi. And there is a 785 number. If that person wants to say hi, we would love to hear from you. All right. And I'm saving the best for last here. So Chevelle, why don't you and Tara introduce yourself, and then we'll transition into Dr. Nye.
Yes, I think that number is Tara. That's
oh, that's Tara. Okay.
Yeah, so as Dr. Clem said, my name is Chaveli, and I am the enroller specialist with the Early Detection Works program.
Great. Well, we're really glad to have you tonight. And Tara, do you want to say hi? She will join us in a little bit. And Karen, I noticed you joined in. Why don't you say hi?
Hi there, I'm Karen Dennis Collar from Masonic Cancer Alliance. Nice to see everybody today.
Great. And then Dr. Nye, I'll let you introduce yourself and then we'll jump into the content for tonight.
Hi, I'm Lauren Nye. I'm one of the breast oncologists at the KU Cancer Center and focus a lot of my work on breast cancer prevention and early detection and risk reduction.
Great. So we really appreciate everyone saying hi. I know it kind of puts you on the spot, but that's how we build our community and get to know each other. So we do appreciate that. And I think the great part is I feel like we've gotten to know some of you a lot better through our Survivorship ECHO. So thank you all for your continued participation. And I do think tonight we will cover some pretty fun information. Hopefully, oh, don't look at my messy desktop. Hold on a second. Yes, it does fit with my personality though, so that is what it is. All right, here we go. So these are all the folks who are overall part of the ECHO, and as you all know, different people come and go depending on the topic, so we're glad you were all here tonight. We are recording this session, so if that does make you uncomfortable, please feel free to kind of turn your mic or your camera off, but it is in confidence and we are a circle of trust here in the ECHO. So remember, we do like to hear you, we do like to see you. You guys are great with the chat box, so keep doing that. But if you're comfortable putting your camera on, please do so, and go ahead and let us see you and engage with you in both audio and video form. So we do use some poll questions. So for those of you who haven't used a poll before, what will happen is we'll start with the next slide doing a test poll. You'll answer the question and it will put up anonymously the responses so that we can all see those responses, but it doesn't identify you as being the one who answered in any particular way. So here's our test. The first poll question of the night: are you familiar with the National Breast and Cervical Cancer Early Detection Program? In Kansas, we call that the Early Detection Works. In Missouri, it's Show Me Healthy Women. And Tracy's gonna pop up, or am I popping up? There we go. So just hit yes or no, and we'll test out and make sure you hit submit. And then we will go ahead and put the poll up. And then in the subsequent polls, we will ask you to put some comments in the chat box if you're comfortable. All right, Tracy, we can pop those up. There you go. So most of you are familiar, which is great. And for those of you who aren't, we will, by the end of our night, you will be. So the good part is we will reinforce some of the new guidelines, and hopefully everyone will learn a little something new tonight. All right. So we're going to start with some risk stratified discussion, and I'm going to turn it over to Dr. Nye, and I'll periodically kind of add some questions in as she goes over why it's important to understand our patients' risks so we can appropriately recommend cancer screenings to them and utilize some of the programs, obviously, that we've talked about in making sure patients can get access to the appropriate type and frequency of screening. So Dr. Nye, over to you.
Thank you. So what we wanted to start out with is just going through kind of the standard guidelines, first high-risk guidelines, and just realizing that most of the standard guidelines that are out there that we're going to talk about are in place for average risk individuals. And then there's a separate set of guidelines that are typically a little more difficult to find that apply for higher risk individuals. And those are typically provided by the professional societies for those cancer subtypes. It's really important, in one of Dr. Klemp and I's life agendas, is to stress that each individual person needs a risk assessment, so appropriate risk stratified cancer screening can be discussed, because without knowing what someone's risk is, you can't really communicate with them about what they should be doing for cancer screening and what would be beneficial to them.
Are you able to move the slides, or do you need me to do that?
Oh, let me see. I don't
Try.
think
You
I
may have-
can.
Okay.
No, I get
All
a
right, then
sound.
I'll be your assistant.
Perfect. So there's many things that come into consideration when we're looking at risk assessment, and it does depend on the cancer subtype that we're trying to risk stratify, but family history and personal history are always major risk factors. We're learning more and more about genetics. We know as individuals age, they're more likely to develop cancer. And then there's other risk factors that are more individualized that have to do with exposures, such as radiation, environmental exposures, HPV, smoking, or prior biopsies, colon polyps on a colonoscopy.
All right, did you want me to move forward? Sorry about that.
Yep.
Okay,
yep, next slide. And so before you start talking to someone about screening, we have to think about risk versus benefit. And you hear a lot in the media about the benefits of early detection and cancer screening. And then you hear a lot about, on the flip side, that maybe it shouldn't apply to all, that there are risks to cancer screening. And so the benefits of cancer screening are early detection. It decreases morbidity by detecting cancer earlier, so maybe individuals don't have to go through as intense treatment. And some screening does not show a significant mortality benefit. So that's some of the big arguments coming out recently, especially I know the U.S. Preventive Risk Task Force, I think, is getting ready or did update the lung cancer screening this week. And a lot of the arguments are that it hasn't shown a significant mortality benefit. And so it's just recognizing that when you're counseling patients on screening. And then the risks from cancer screening can be false positives. So asking a patient to go through an invasive procedure such as a biopsy that can cause harm potentially. The cost associated with some of those diagnostic tests and workup. And then there may be some additional radiation exposure if additional X-ray imaging or CT imaging is needed. So this is one of my favorite slides. When we think about components of risk analysis, this is from the U.S. Army Corps and how they educate about risk analysis. And the same things are true when we're talking about cancer risk stratification and that communication of risk. First, it takes a risk assessment and an understanding of what the risk truly is. And then it takes an understanding of what the management of that risk would be, whether that's preferences of the individual or policies that are in place. And then that is all encompassed with risk communication. So a back and forth between the educator and the person who's at risk to determine what is the best screening modality for them. And so when you have risk stratified cancer screening, it really begins with a provider assessing an individual's cancer risk, that communication to the patient, so a patient-provider discussion of risk in cancer screening, and then a patient decision on cancer screening. So the autonomy does fall onto the patient. It is not just telling the patient you need to do this, this, and this. There needs to be a discussion so that they understand why that's being recommended. Otherwise, you're not going to have someone understand why they need to follow through with that recommended screening. And it's no fault of their own if they're not educated on why that screening is being recommended.
And Dr. Nye, I think some people feel that maybe that takes a lot more time in a clinic visit, but it really doesn't have to. So, you know, is it more getting people comfortable with those risk factors? Is it more that people just need to kind of think through what their current workflow is? Like, what would be a good way to tackle this improved workflow for some of the folks on the session today?
So first, it is the provider has to recognize that they have to think about the individual's risk. Simply saying, go get your mammogram or your colonoscopy is probably not going to be enough. And in order for them to understand that individual's risk, they're going to have to understand some of their history. So whether that's utilizing in your workflow a team member that
I was going to go
collects
to
that.
your intake forms. So sorry.
Personal, oh, I don't know if we have that, that collects the personal history, or whether you have a patient handout that they fill out that documents their personal and family history. There's a lot of tools and calculators that we'll talk about that can calculate an individual's risk that can be done ahead of time and don't have to be done during that encounter. And a lot of education can also be provided in handouts and information, so that a patient maybe is prepared that this is what we're going to talk about at your visit. Patients are empowered with knowledge and information, and if we just give them the information that they need, they're happy to learn and try and understand what may be recommended.
Great.
And so these are the breast cancer screening guidelines that we tried to lay out some of the major organizations that develop breast cancer screening guidelines. So in the primary care setting, we mostly rely on the U.S. Preventative Service Task Force recommendations, and those are screenings that apply to only average risk individuals. And they are now recommending a screening mammogram every 1 to 2 years for women 40 and older. This is consistent with the NCCN, or the National Comprehensive Cancer Network guidelines. That tends to be the guidelines that are followed by oncologists or high-risk providers like myself. And they recommend the screening mammogram should include tomosynthesis if possible and begin at age 40. And then the American Cancer Society kind of breaks down between ages 40 to 45, making it a personal choice based on risk, 45 to 54, going ahead with the annual mammogram, and then 55 and older, considering annual versus every 2-year mammogram after discussion with their provider. Really, the only high-risk guidelines come from the NCCN, so that specialty society, and those kind of guidelines can include the yearly mammogram, can include an annual breast MRI, as well as a clinical breast exam. And all of those links to those different guidelines, I believe, will be in your toolbox or your toolkit.
Yeah. And so this is one slide where if we actually went to the CDC's website, they have a grid that's even more comprehensive than this. Mm-hmm. And for many primary care, it's overwhelming because you could have 8 different organizations with similar yet a little bit different guideline. So when we would talk to our primary care partners, you know, or even our partners in oncology sometimes, you know, what are the best guidelines for them to follow? And then I'd also like Chevelle and Tara to talk a little bit about how they address this when they're talking to their primary care partners in the community as well.
And I do think it does put a huge burden on primary care providers. I mean, they are addressing so many different chronic illnesses and, you know, risk reduction of many chronic illnesses, even in a well person visit, that talking about different cancer screening guidelines can take time and maybe a whole nother visit that they probably don't have time to fit into their calendar year, an extra visit for every person to talk about cancer screening. But I think that's why many of them rely heavily on the USPSTF guidelines, because they really are developed for average risk individuals and to do the least amount of harm to average risk individuals. There just needs to be a screener in the clinic so that they can identify if somebody's higher risk and, hey, these guidelines don't apply. And maybe they would go through those steps of counseling them on what the screening would be based on their risk. Or maybe they just need to have a referral pattern in place for somebody who in their area may be the expert on that higher risk individual.
Great. And how about Chevelle or Tara? You know, are you doing that similar type of recommendation? How do you educate the community providers on which guidelines to follow?
Actually, the program uses the U.S. Preventative Task Force, so we pay for the mammograms every other year. That's for average risk. But if they have family history of breast cancer, then we will pay every year for the breast screening, or depending on the results.
And I believe, correct me if I'm wrong, I believe the EDW just reduced the year that they'll start their screening to 40 this year, correct?
Yes,
for mammograms.
Yes, they changed the guidelines because we used to start at age 45, but February of this year, it was reduced to 40. And for the cervical, we are starting at age 21 now, and it goes to CBE as well.
Awesome.
Fantastic.
And does anyone have any questions in regards to these guidelines? Put it in the chat box, or do we want to have a little more discussion? So you guys chime in if you have any questions on the guidelines. And we're going to talk a little more about the EDW criteria here in a few, but I don't want to, you to have a burning question and not get the opportunity to ask that. So anyone?
Jennifer, this is Peggy. I'll put mine in the chat box because I've got a question about for older women, so I'll put it in the chat box.
Okay, but we may want to bring it up, so just be prepared. Okay. All right. And as Dr. Nye said, here are those guidelines, and they will be in your in the toolbox. So remember, anytime you see the little red toolbox, we've aggregated those resources for you at the Masonic Cancer Alliance website, which we'll show you at the end. So this leads us into a little bit more in depth where here's the contact information for Tara and for Chevelle. This will also be available in the toolkit because you'll have all your slides, and also on the website. So let's talk a little bit about those guidelines, Chevelle, that you highlighted, and kind of talk through sort of how you do this assessment and how is the income collected, sort of what is that process?
Yes, so the early detection works is the state of Kansas free breast and cervical cancer screening. And as I mentioned, we start at age 21 for the cervical screening through 64, and the mammograms at age 40 or the breast screening. So for a participant or a patient to qualify for the program, they must be a Kansas resident with no health insurance and who meets the income guidelines. And these guidelines are updated every year, every spring. So we also pay for diagnostic, not only screenings. So in the case that the patient has an abnormal mammogram or abnormal pap, we will pay for a breast ultrasound, diagnostic mammogram, breast biopsy. And for the cervical, we will pay for a cervical colposcopy, cervical biopsy, and other diagnostic services. So to qualify for the program, the enrollment process is really easy. The patient needs to call this number, the 877-277-1368. You press 1 for English and you press 2 for Spanish. I'm the one in charge of the Spanish line. And the process takes about between 7 to 12 minutes max. We will go over the application. I will ask them questions about demographics, income, is what they report to us. They don't have to provide any documentation. It's just through the phone. And at the very end of the application, I will know if the patient is eligible for the program. And I will provide the patient with an enrollment ID. It's a 7-digit number. And then the patient needs to call the clinic to schedule their exams. And the code is good for up to 6 months. So that way we make sure that the patient has more than enough time to schedule their exams at the clinic and then go to the hospital for those, for the exam, for the actual mammogram.
Okay. And Chevelle, let's say that you find something on, you said that you cover all through diagnostics. So on a biopsy, a patient's positive, but as you alluded, when they joined the program, part of that was they couldn't have insurance. What happens at that point, and how do we help them get to their next step for accessing people like Dr. Nye and treatment choices and so forth?
Yes, so if a patient is diagnosed with either breast or cervical through EDW, we have an agreement with Kansas Medicaid, which is the KenCare. So they will expedite a treatment, a medical card. They call the program is Treatment Act. So they will expedite this medical card so the patient can start treatment right away. I don't know if Tara is able to join. If you want to speak a little bit about this, Tara.
Hi, can you guys hear me now?
Yes, Tara. Great.
Oh, great. Okay, wonderful. Sorry about that. I'm full of technical difficulties today. So yes, the Treatment Act, that is honestly one of my favorite parts of our program. So if a woman is diagnosed with breast or cervical cancer while they're receiving treatment through our program, we are able to complete an application to Medicaid on their behalf. And we have an agreement with them that they will process our application within 10 business days. And it is a one-page application. That is it, one page only for the patient to complete. We ask for that application, a copy of their ID, and the pathology report that diagnosed them, and that is all we need to submit to Medicaid. Medicaid will cover them for the duration of their treatment, and when they have finished treatment, they can return to our program for their screening needs. Unfortunately, the only downside to this agreement is that the patient does have to be a U.S. citizen or here legally for at least 5 years. And in those cases, we try to connect the patient to resources within their community that might be able to help. Those are not our favorite, but I do love that agreement with Medicaid. It's an amazing resource for our patients.
Absolutely. And so Carol Bush wants to know then, as you're kind of helping the patient navigate, because that's, Tara, part of your job as the nurse, I'd like you guys to each kind of say what you do, but can they kind of go to any facility, or do you have network providers, or how does that work?
No, that's a good question. We actually have providers through the whole state of Kansas, but we do have specific providers that are contracted with our program. And to get paid for the services, they do have to have that contract with our program already in place. We welcome any and all providers that would like to be involved in our program. But if a woman calls and they're referred for someone that's outside of our network, we try to connect them to a provider that's close to them, that would be easy for them to access, that would be able to help them with the services that they need.
Great. Very good. And so as a nurse, Tara, are you helping, you know, on the front end throughout? Like, what is your role, and how do you and Chevelle work together or in tandem?
Yeah. Whenever I get asked about my role, I can never come up with everything that I do. It's a loaded question. I mostly, I feel like, do payments. So I do a lot of processing the payments and making sure that they're clinically accurate when they come in. I receive them through our online data portal. I also receive paper claims that I process. But I am involved with enrollments when they are outside of the typical guidelines. If there is a patient that is symptomatic that does not meet our age guidelines, I may be able to help. So I do work closely with Chevelle. If she gets any patients that are Spanish speaking that I cannot speak, you know, I can't talk to, she'll assist me, and she will call and get approval from me if needed. But if they are within our guidelines, Chevelle is, you know, absolutely more than able to enroll them without speaking to me. And she does a lot of, she is an amazing resource for our program.
Let's kind of go to that side as Chevelle talks about that, because this is your state map that we're showing right now, Tara. And so
yeah, thank you.
Do you cover a certain area? Chevelle, where do you cover? Like, how does that work? Are there many of you, Tara, or are you the only one?
Yeah. So there's 4 of us. I'm up here in the green section. Green. Right. I'm green. So my little square looks small, but we have a lot of providers within that area and see a lot of patients. We have Anna and Debbie and Shelly, who are also with the program, that serve different regions. And Chevelle manages, I'll let her speak to it, but she gets a lot more patients than I do. Chevelle, do you want to talk about what part you manage?
Yes, since I get the Spanish line, I get all the calls through all the states. So I enroll from Tara's region to Anna's region, the whole state.
Very good. So wherever you are, because we have folks from across the state on tonight, make sure you have Chevelle's number, and make sure you look at your color where you are, and make sure you know Debbie, Anna, Shelly, or Tara, because these are great people for you to have access to. I know on my bulletin board in my office, I have their numbers, and I used to call someone who's probably a tier or 2 up, because I just wanted to have one number, but now I have everyone's number, and it's really helpful. And make sure that our teams, I mean, these should be sort of everywhere and easy to access, so that we can find our partners with EDW. And then the next slide I do want you to go over too, because this shows what's happened as a result of COVID. And since our discussion really has to do with kind of the impact and how we get patients back in, you know, Carol Bush is asking some fabulous questions, but in sort of condensing that, as you think about getting patients back into the program and enrolled, how do we also at the same time get those providers enrolled, and do they call you, Chevelle? Do they call Tara? So just give a little bit of overview of this slide and how a partner would become a partner.
Yes, and before that, I received a private question from Angela. She said regarding if men are eligible for the program. And yes, it's weird, but we sometimes get 1 or 2 a year, and that will go to the nurse manager, Suzanne Proctor, I'm sorry, and she will approve depending on the case. So we have seen those cases where men get approved through the EDW.
Great.
Yes.
Can I Chevelle, I was just going to point out when we talked about the high-risk individuals, last I checked, early detection work does support mammograms in individuals even before age 40 if they have a first-degree relative and it's indicated. And so they do have some flexibility there. And so those high-risk individuals can still be served by the early detection works program.
Yes, that's true. That's absolutely true. It doesn't matter the age. If you have family history, we will pay for that mammogram, and that's where I will might need the nurse approval because she's not on the age criteria, but because of the family history, and because of that, she will qualify for yearly mammograms or yearly screenings. Yes.
And I will add that we are able to screen women under the age guidelines if they're symptomatic as well. So even if they don't have a first-degree relative of breast cancer but are experiencing a concerning symptom related to breast cancer, I can enroll them under the age guidelines as well.
Yes, and if the participant speaks English, I will refer them to Tara, and she will finish the enrollment. In the case that they don't, Tara will give me the approval, and I will continue and do the enrollment myself.
Great.
Okay. So here in this chart, this is the total enrollments versus the number of services received. This is from January through June 2020. So here, as we can see in January, we have a total of 506 enrollments. And of those enrollments, we have 417 services received. So an average or difference of 89, I believe. So then the numbers went up in February, and that's usually what happens as the spring start coming up, as more events, more awareness about breast and cervical, people start calling and getting enrolled to get their exams done. But this number, after when it's here, February, it keeps going up. But because of COVID-19, I mean, as you can see, the numbers went down. After that, in May and June, the numbers went up. The screening or number of services received for May and June are not really accurate because it can take between 3 to 4 weeks to get scheduled and actually go to your appointment. So these numbers, I would say, are not 100% true yet because it's really recent. I pulled the data few days ago, so this is very recent. But because of COVID-19, we can see this little curve going down. So hopefully we can see that it's increasing here now.
Now, Chevelle, one thing that I know that we had happen in our imaging center, obviously we were still seeing patients who were symptomatic or had palpable issues during COVID. Would we assume that the March, April, May numbers that were screened, were those women symptomatic or had palpable issues? Or because unfortunately I will want Dr. Nye to comment, the patients that we're seeing with new diagnoses are not those screening cancers, the nice little guys that you just happen to find on a mammogram. So there's this sort of phenomenon that's happening that curve, that dip, those tended to be, at least in the imaging centers, more of those palpable symptomatic patients.
Yeah, so I don't know, it may be a little bit of both actually, because they call, we enroll them, and they will schedule their appointments. Now we know that it's taking about 3 to 4 weeks or 6 weeks to get scheduled. So I don't know, that might be one reason, one factor.
And Dr. Nye, did you want to comment on that about, the importance of sort of how we're easing back into screening, and we'll dive into sort of that risk stratified model, but any comments you wanted to make on that?
Yeah, and I think in Kansas City, we shut down a lot of our imaging centers for a short period of time. I'm not sure if that held true throughout the state in the less populated areas. They may have remained open, so that may be why we're seeing still a pretty high number of screenings being done. But during the time between mid-March and now, yes, most of the diagnoses that we've been seeing, or at least it seems that way, are individuals who had a palpable mass and went in for diagnostic imaging, or had a biopsy done based on the follow-up imaging, not the smaller screening imagings, although we're starting to get those back in the last few weeks again. They're seeing that in many different cancer subtypes. I think you're going to talk about later, but I think it's even a bigger issue for colorectal cancer screening because of the procedure of the colonoscopy and the fear of the expectorating the virus.
Right. And Dr. Greiner has joined us. So Dr. Greiner, if you want to chime in as well from your vantage point, please do so.
Okay, thanks.
Great, you bet. All right, so let's put risk into context. And this is Dr. Nye's favorite slide, I think. So I'll let her describe that, and then we'll talk about a little bit of risk assessment and then dive into our cases and into colon cancer.
I actually, when you sent this out last night, I was thinking about how up until January of 2020, this held true, where most public, the public outrage or the public concern for what's going to affect their morbidity or mortality are things like plane crashes, the ozone, terrorist attacks, when in reality it's cancer, heat, car accidents. And this is a pretty old image. But if you consider COVID terrorist attack, I feel not really, but as a pandemic, then I think that yes, cancer has really been pushed to the side in terms of the public's concern for reasonable reason. I mean, the COVID-19 pandemic is serious and it's going to affect many people. But we're going to see increased morbidity and mortality from cancer if we don't get back into screening. And so I think if we change that circle to COVID, then in reality, it is a real risk, but the cancer risk is still there.
Right. And so let's kind of jump into another poll question. You can also add into the chat box. We'd love to hear your thoughts on if you're currently providing any type of basic risk assessment or that risk stratified vision that Dr. Nye described in your practice or in the organization that you work with. So Tracy's going to pop up the poll, and you guys go ahead and answer yes or no, maybe or not. And then any comments in the chat box would be great. All right, Tracy, maybe our poll is not popping up. That's okay. I'm looking at her face. She's like, so we will just move on. So just put in the chat box if you have any thoughts about, are you doing risk assessment? What are your barriers to doing any type of risk assessment? And we're not going to dive a lot into the hereditary topic tonight. We did have a whole echo about that last summer, and we'll cover this towards the end of the fall, again, in a little bit more detail. But we'll just do a quick overview of the importance of genetic risk assessment as part of that risk stratification, both for breast, colorectal, and multiple other types of cancer. And Dr. Nye, back to you.
Thanks, and I won't focus too much on this since we have talked about it. And then for the toolbox, I'll give you, my editorial was published for the American Family Physician that kind of summarizes these slides. So when we're talking about cancer risk assessment in an individual, now what's come to the forefront is, genetics really do play a role in cancer risk, and the U.S. Preventative Service Task Force updated their recommendations last year in asking primary care physicians to assess a woman's hereditary cancer risk based on different family or personal histories. And like we've talked about, that's a pretty big burden on a primary care provider, but there are some pretty easy tools to at least risk stratify again and then develop your framework of what's your referral pattern. And so these are two of the tools that I picked out. If you look up the whole report from the U.S. Preventive Service Task Force, they list several tools, but going through them, this 7-question family history screening is probably the most ideal to hand to a patient in the waiting room, have them fill out, and then turn in to the physician or nurse or clinical team as they're being roomed. And if they have one yes, then it triggers a referral for genetic counseling. You can go to the next slide. And then this is the pedigree assessment tool. So this tool seemed more ideal for the provider team to complete. So looking through the individual's personal and family history and calculating a score. And if it's 8 or higher, that triggers a referral for genetic counseling. We're seeing more and more OBGYNs do their own genetic testing in the clinics, but I haven't seen this translate into internal medicine or family medicine at this time. So I think that just having access to genetic counseling is necessary, whether that's telegenetic counseling, which is much more readily available, or a referral to a genetic counselor if there's one close to you, but I know that is not very common in Kansas.
I'm sorry. There we go.
And so how to put this into your clinic, this is similar to just the cancer risk assessment, but take a family history, use a screening tool for genetic risk, have your referral pattern for genetic risk assessment and testing, and then have a plan for management of those high-risk individuals. And realize that negative genetic testing does not imply low risk. They're probably at high risk if they had something that triggered you to refer them for genetic testing, and that family history-based risk still remains even if their genetic testing is negative.
Yeah,
and so really,
exception right there. That is a take-home message that patients interpret their risk as being less than it actually is just because they have a negative result. All right, and so let's jump in real quick, like to review how EDW and the clinical management of a patient who presents with shouldn't be a break in that care based on lack of insurance.
I did want to mention, I'm so sorry, related to the genetic testing, that's another area where we can enroll people outside of the normal guidelines. So if there's a patient that had genetic testing that places them at high risk, they just need to speak to me again. That would be a patient that I would need to talk to, but I could assess that, get that documentation, and get them enrolled as well.
Great. And you also said that as you fast track patients to CanCare, or if it's Sunflower, whichever provider they have, they are very good at paying for genetic testing. So once again, that's not a barrier just because they have Kansas Medicaid. They actually reimburse genetic testing pretty well. And Dr. Nye, I don't know, have you ever had a denial from Kansas Medicaid? I have not, so.
Not that I can think of, but I wanted to say that during COVID, I have, given patients the information for the EDW. I think it's been really helpful. I see a big panel of high-risk patients and breast cancer survivors, and they are losing their jobs and they're losing their health insurance. And we just talk about that they just have to call if that happens, and we will get them referred to the EDW, and we'll just touch base again once they find a new job or get their health insurance back. But it's been a big ask.
That's great. Thank you.
Any other questions or comments from the group as we transition into colorectal screening? Right, you guys are very chatty on the chat box today. So we did want to ask you, which guidelines are you currently following when it comes to colon cancer screening? And hopefully, Tracy, does this poll pop up? I hope it does. We do have some prompts for you. There you go. If you click the one that you most commonly follow, that would be great. And then hit submit so that we can see kind of where your benchmark is. And feel free to chat in the chat box about those recommendations that you're following. All right, and we'll pop those results. So as you can see, most people are following the same as we do for breast imaging, but there are quite a few of you using the NCCN guidelines as well. So that once again can pose some confusion as we try to really get some consensus around screening guidelines. But Dr. Greiner, when you take this into account and you're thinking about sort of this patient and your expertise in colorectal screening, and please introduce yourself as well, you know, how do you take these factors into account, and which guidelines would you recommend following?
Yeah, so I'm Alan Greiner. I'm in the Department of Family Medicine here on the Kansas City campus, but have done a lot of projects on trying to promote colon cancer screening across our catchment area. A lot of stuff in safety net clinics here in Kansas City. But I think the primary thing that's probably drives me is insurance coverage. So with, say, the ACS guidelines, for example, and their recommendation that you start screening at age 45, which is based on some new data in the last year and a half that's showing an increased incidence in younger adults of colorectal cancer. So there's sound data behind that, but a lot of the insurance coverage, insurance companies have not caught up to that yet, and most of them are recommending screening for average risk adults at age 50, beginning at age 50. So that's a slight issue there. There's really not a whole lot of difference for average risk folks between USPSTF and the NCCN guidelines. I do think for high risk individuals, there's a lot more available with NCCN's recommendations than there are for USPSTF, which doesn't really get into it a whole lot. But you can see here some of the things that put a person at increased risk or high risk. The big thing to remember here is if you have people with increased risk or high risk, they're definitely going to need colonoscopies for screening, and they're going to need those on a more frequent basis than folks at average risk. And again, they much like we were talking about with breast, they may be people that are going to fall into the categories where they need referral to genetic counselors or referral for genetic testing. And in my practice, I'm fortunate enough to have genetic counselors here at the Cancer Center and a lot of support for that. But I do think it's important to remember to take that family history, because there really are a lot of folks that have family history for colon cancer or various colon polyp related syndromes or issues. There are patients a lot of times who don't know the names of the issues that they've had in their family. I've seen that a lot. I don't know if others have experienced that, but people don't necessarily know about Cowden syndrome or Lynch syndrome or some of these. But taking that history gets you started down that path, and then a lot of times you'll be collaborating with multiple colleagues on these, because you'll be ordering colonoscopies, working with your GI providers who are doing those, and again, in some cases, you'll be working with genetic counselors and others who will provide input there.
And we did include, which this may be more than what most people are going to want to use, but we did include the PREM model, which now they're at PREM 5, and this is through Harvard, and we've used this since it came out. But this is a really easy, quick tool to help us understand, based on colorectal cancer, endometrial or uterine cancer, other types of cancer, and the polyp count, where someone would fall in the likelihood of having one of these hereditary mutations. So we just thought we'd include that so you have that reference. And it's a nice tool to have kind of in your back pocket. And you did go over, these guidelines, and I wanted to jump into the different types of tests real quick, just because I think that there's a lot of choices. And so, as you said, a patient who's at higher risk should absolutely have a colonoscopy. We have the luxury at KU of having a high-risk GI clinic with GIs who are very comfortable managing that higher risk population. But what about just the average patients, and how are they choosing, or how do their physicians choose which of these tests to order?
Yeah, so it's been interesting to watch this over time. There was a time, I think about 15 years ago, where most providers were moving to the idea that colonoscopy would be a preferred screening modality for even average risk folks. And I've seen that shift, I think, a little bit in the last 5 years or so, maybe even less, maybe in the last 3 years, where people are remembering that really the best test for colorectal cancer in average risk folks is whatever test the patient will do. So we've got people that, you know, that do have problems following through and getting a colonoscopy. I've had many patients over the years who will say they'll do it, we'll get it scheduled, and then somehow it ends up getting canceled or rescheduled multiple times and never done, and things like that. And so doing one of these stool-based tests or one of these tests that's simpler, I don't think that there's many clinicians still doing flexible sigmoidoscopies around. We used to do them out of primary care in outpatient settings, but there's not quite as much of that happening. And a lot of providers do feel like the fecal immunochemical tests, the FIT kits, have better test specifications and sensitivity specificity than the guaiac-based fecal occult blood tests, although there are high sensitivity fecal occult blood tests now that are available. But FIT testing is a good annual option. We've done a lot of work with that in the safety net clinic population in our projects, and found that the positivity rate is really relatively low. So you don't end up doing a lot of colonoscopies, but you also have good evidence from the larger studies that have been done that this does reduce colorectal cancer mortality over time. And then the FIT DNA testing that's come on board and is now covered by almost all insurers. I don't think it's still
And would
covered
that
by
be like a Cologuard? Is that what that is?
Cologuard. So yeah, people have probably seen the TV ads where the little blue box is running around, right? And the blue box gets sent to your home, and so you can talk to patients about Cologuard, and a lot of times they've heard of it. I don't think Kansas Medicaid is covering Cologuard yet. They've had some problems with that population, but otherwise it's pretty well covered now. And it's an every 3 year, generally an every 3 year scheduled test if it comes back normal. Now with any of these stool-based tests, if they do come back positive, a person will need to have a follow-up colonoscopy. But we've found in our projects that once people have done the test, if they have a positive, they're going to follow up and do the colonoscopy. We don't seem to have people fall through the cracks on that, and so that's a good thing. In that once you start down that pathway, you tend to be okay. For CT colonography, which it does require a bowel prep like colonoscopy, but you need kind of a specialized center that does a relatively high number of those. So if a person or you have patients that are interested in that test as a method, it's a good test, but you want to do it at a place that that does hundreds of them a year, not a place that does 5 of them a year, because you want a radiologist looking at that's got a lot of experience with it.
So you talked about the FIT test, and did you order more of those during COVID? Because obviously, at least in our facility, we did, kind of close down a lot of screening. Probably the catchment area didn't close down like we did. But overall, this is from the colorectal roundtable that we will have in your toolkit. But I think this was some interesting data, just showing the decrease in the colonoscopies and biopsies and what that's going to do kind of to this longer term picture. So how did your pattern change, and are people getting back into it, and are you triaging those patients, trying to get your highest risk patients back in first?
Yeah, we are. We had a whole lot of colonoscopies that got canceled and pushed back. Most of those have been pushed to even the fall. So we're trying to get higher risk folks with inflammatory bowel disease, or folks with those family histories or syndromes like polyposis or Lynch syndrome in this summer if we can. This data is really dramatic, how much things got pushed off and delayed, and it's tough because everybody's on a schedule with these different tests. You might be on an annual schedule for your FIT, you might be on a 3-year schedule for your Cologuard, or a 10-year schedule for your colonoscopy, or a more narrow window for your colonoscopy. If you've had adenomatous polyps on a prior colonoscopy, you're probably going to be on a 1, 3, or 5-year cycle of getting repeat colonoscopies, depending on what your GI is recommending. But this is going to take us time to catch up with. We did have some of our staff going through our health maintenance tabs on patients here in our system, and then trying to get some messaging out to them about the stool-based home testing. We've done quite a bit of that and did some during the down period, but even with that, I think because there just wasn't as much going on, we're going to have a lot of catching up to do.
Absolutely.
And we don't want to have these excess deaths because we haven't caught up. It's going to be important.
And this is the National Colorectal Cancer Roundtable. This just came out. And so, as I said, it will be in your toolkit. But I think kind of interesting just to aggregate that data and to think about, we do have to get patients back in for screening. We do want to get the highest risk ones in first. So this is a team effort, and being able to approach it that way is important. Do we have any programs like EDW to help with colorectal screening, or is that an opportunity that still has yet to be met?
Yeah, we've never had one in Kansas. There were some states that had demonstration projects funded by CDC to do that. I don't know if I don't think there's near as many as there were at one time. But there's continuing advocacy at both the national and state levels to try to get something for colorectal in place, like we have for EDW with breast and cervical. I think it's the way to go, and we'll get there eventually, because the data is really good that colorectal screening reduces colorectal mortality.
Absolutely. So I know I kept you guys a little, like 5 minutes over, and so I'm very sorry, but I didn't want to cut off that great discussion. I think we've had some good tutorial and sort of recap as to how we need to be encouraging patients to get back into screening. We've had these dips. We have some programs that we are underutilizing, and we need to use our partners at EDW to help patients access care. And I think we need to be making sure that we're taking that good family and personal history, so we're risk stratifying the screening for our patients. As we wrap up, make sure that you have access to get your CE, but any other quick questions or comments? I know that a lot of you put some great comments in the chat box. We've tried to reply to those. You'll have a lot of tools in your toolkit, but any last minute questions, any last minute comments anyone would like to make? I hope this was valuable to you guys. I think I learned something. I hope everyone else did as well. I want to thank our experts, Dr. Nye, Dr. Greiner, Chevelle, and Tara for joining us tonight. And please be sure to go to our web link where you can watch this again if you want, share it with your colleagues, and access those tools in the toolkit. So thank you all for your time, and we'll see you next month, August 12th. At 4:30, and that is not the right topic, sorry. I was sloppy with my slides. We're gonna be talking about comorbid conditions in cancer survivors. So we'll hopefully see you next month. All right, and you guys be safe, and thank you. Bye-bye.